of these old days, one of these old days, and we won't.
What is up, everyone? We are back here, Transitions from War podcast, episode 45. I'm your host, Mike, and as always, we're talking about reconnecting to mind, body, and spirit, the journey of coming back from combat and back to an active lifestyle. I'm excited to bring you guys a nice two-parter. So today will be part one of a two-part episode, and I had the pleasure of interviewing Dr. David Lunow out of the Dallas-Fort Worth area. And he's actually the first guest to actually fly out from Texas to be interviewed. So we sat down, met up, and we had a lot to talk about. And even this two-part episode, we decided it wasn't enough for everything we needed to cover. So you guys are going to enjoy this. Dr. Lunow, or Lunow as he likes to be called, born in Minnesota and raised in Indonesia, he has a pretty unique growing up experience. After spending a lot of time abroad, he eventually got his medical degree, and he's been practicing ER medicine since 2006. So Dr. Lunow has founded Apex Health, and it is uniquely catering to men's health needs. And so, among other things, we talk a lot about sleep, diet, the roles different hormones play, and he's especially knowledgeable in the area of testosterone. And what makes Lunow unique in this area is he doesn't want to just pump people through testosterone replacement therapy, but he wants to find out what's really causing low testosterone among men and fix it in a way that doesn't involve pumping people full of drugs if he doesn't have to. He likes to look at people's lifestyle, their diet, their exercise, their sleeping patterns, stresses in life. Anyways, we get in a lot of cool stuff, and so we're going to have some links to the show notes so you can find him, and he's at apexmenshealth.org. Anyways, Dr. Lunow is the official doctor of the Transitions from War podcast now, so we're going to have a lot more episodes to come, so everyone stay tuned for that. Hope you all are doing well, and enjoy the show.
One of these old days, one of these old days, and we won't.
Welcome to Transitions from War to the podcast. I mean, this is so cool. You flew out from Texas.
Yes. I'm happy to be here. It's
He's
awesome.
the first out-of-state guest, which is awesome.
Oh, really? Oh, okay.
Yeah, in person.
Okay, gotcha.
Yeah, and so I know you're also our first donor to the show. I remember that when I misread your name on one of the episodes.
You added a letter to my
I think I added an extra L to it.
Ludlow, I think is what it was. It came across or something. Yeah. So for the record, my last name is Lunow. But anyway.
So yeah, Dr. David Lunow. And do you go by Dave? David, what's your...
That's funny. I go by Lunow, actually.
Lunow?
Yeah, I have a twin, and his name's John. And he was always called John, and I was always called Lunow. And so...
That's awesome. That's like a lot of people, I mean, you know, when we're in, you know, military-wise, people usually refer to us as their last name.
Yeah.
And then all of a sudden it's like, you know, get home and then I'm Mike again.
Yeah, exactly. Well, you know, at home, my folks call me Davey, so you know,
yeah,
they're the only ones that do that, you know. But I think, you know, being on sports teams and stuff, you know, everybody calls my last name or your nickname or something becomes your identifier much more than your actual name. So oh, okay.
And then, so yeah, welcome to the show. I mean, it's an honor to have you here, and we're going to get into a lot of cool stuff. And
cool.
You talk about you have a unique perspective that we haven't gone into on the show before because you work with a lot of first responders and vets.
Yeah.
You know, professionally, clinically as a doctor, and you're also a friend to a lot of vets and first responders. And so you have that unique perspective to see things two different ways.
Yeah. Just a little bit of my background. So I'm an emergency room doctor in Fort Worth, Texas. But I'm also boarded in family practice as well, which is actually probably pretty good because half of what walks through the emergency room doors are actually clinic-related stuff, not like true emergencies. So, and I've been doing that for 15 years. most of my friends are either firemen or police officers, EMS type first responders, because I see them a lot. We see them at work, together, and they bring patients in and we talk. And some of them are also paramedics that also work in the emergency room, with me as well.
Yeah.
So that's sort of how I got more involved with that whole segment of society. And then a number of them are also military vets, Afghanistan, Iraq.
Right. You're just you said about an hour or so north of Fort Hood?
Yeah, our sort of Fort Hood is just south of us. And then, of course, there's the Naval Air Station in Fort Worth itself, where Lockheed has their big production line, F-35. So there's a lot of military people around.
Well, there's no shortage of active duty and vets in the state of Texas, that's for sure.
Absolutely.
I think half the people in my boot camp were from Texas.
Really?
Yeah.
Well, yeah, the military is a big thing in Texas. I mean, if you don't know what you want to do with life, go in the military, and that's a honorable thing to do.
Yeah.
So, and then of course, when they get out, most of them, are, their skill set is really tailor-made for, firemen or police officers or something, or EMS, first responders kind of stuff too. And so they find they're uniquely qualified for that too. So,
yeah, and I think a lot of people seek it out too. I've talked to a lot of people who go into a different career field, but then what they like about law enforcement or the fire service is that camaraderie, that teamwork, where you have those tight bonds.
Yeah, absolutely. I mean, most of them talk about that, but then also there's the adrenaline rush part of it too.
Oh, yeah, equally there.
Yeah, it's not nearly as intense as obviously combat, but it's there,
Yeah. And then, this can go into some of what we were talking about earlier offline about some people thrive in that environment when things are chaotic. They get their mind slows down enough to where they can really be there.
Yeah.
And some people, obviously, who don't have experience in that really fall short of being able to handle all that stress.
Yeah.
But vets are a lot of times uniquely qualified or pretty good for some of those jobs where they're able to see bigger pictures where people might shrink and get tunnel vision.
Yeah. Yeah. Well, it's hard to replicate what vet has experienced in the civilian world. I mean, to become an emergency room, either nurse or tech or doc, there's this whole prerequisite education, a lot of kind of stuff. And then the first time you're there, it's like, holy crap, what's going on, and just so many things are going on and your mind is just 100 miles an hour. Where the vet, has the same thing, but he's doing it and he's been trained with the rest of the vets, and when he's in the Army or whatever, in the Marines or whatever, and then they go into combat and then they're able to that is the refining fire, so they're able to, they do their job. You got someone else has got this job, someone else has got that job. You're doing your job, and together it works together as a symphony. Which then that correlates directly into like emergency room care. Everyone's part of the team. Everyone's got their job to do. The physician's sort of the commander. Running the show, orchestrating things. But the vet guys that are come in and work with me, as paramedics or whatever. I mean, they've seen everything. And so they're not too upset by blood or guts or whatever else.
Right.
Like
they don't have as much, they don't have the deer in the headlights kind of look a lot of times.
They're like, oh, okay, I've seen this, what do you want me to do? And like, okay, that's great to have somebody just completely calm.
Yeah.
Because when they're not calm, that's when chaos ensues. And
right. Because then you have to manage them too.
You have to manage them as well. Yeah. It's hard enough managing family.
Yeah.
Outside the patient themselves, the patient may be tanking, the family's decompensating, and you're just like, well, what the hell? And so you're trying to manage so many things at once. The last thing you need is your own staff, decompensating.
Yeah.
Now, admittedly, it is hard when you have a child, because most of my nurses are mothers, and a child gets everybody up in arms. And so trying to calm everybody down and do your job, be professional, take the emotion out of it and recognize that it's a 2-year-old that's dying in front of you, but let's do our job. That's a harder scenario, obviously. And it's even harder, for the military guys that, kids,
of course,
get you at the core of your being. So
I think that's just the core of being human is you see kids, and unless you are a psychopath or, you're antisocial, then you're going to have that primary drive to protect someone young.
Yeah. Yeah, absolutely. Absolutely. And I have to admit, even as a physician, it's nerve-wracking. Internally, I'm all jacked up, more so than like every other scenario in the ER. When I walk through the ER doors, my stress level goes down. I'm in my element, my environment.
Yeah.
Outside the ER, I'm much more anxious. None of those are my environment. And
it's such an interesting thing where, like, even as you're talking about it more, just the parallels with a lot of vets I talk to, and including my own experiences of feeling more comfortable in a war zone.
Yeah.
And then coming back, and simple things like paying bills or dealing with a kid who's having a tantrum or going to a job on time is all of a sudden stressful, and the confusion that comes with that.
Yeah, absolutely. In fact, I read a study on vets and everything, and they were talking about, the working stiff, the guy on the bottom, he's all anxious until the first bullet flies, and then he's suddenly calm and, ready to go because this is what I'm trained for. The commander's the other way around, Once the bullet starts flying, he gets more anxious, and it's weird, just whatever job you happen to have as to how you, process the actual chaos.
I think the common ground in all of this is just the level of control or perceived control people have.
Yeah, yeah.
Because it was so much harder for me when I got out to know the guys I was in with were deploying again. And to be there at home, I got such a big appreciation for the military spouses and families, because when I was there, I knew what I could do to help and be part of it. I knew what was happening.
Right.
And then being home, and I know guys are over there, I don't know exactly where they are, what's going on, how I can help. And that sucked way worse. I rather would have been deployed.
Oh, I can imagine. Absolutely. Absolutely. But, it's like, when the chaos hits the ER, you know what to do. It's already scripted. You've already been here before, so you calmly go about doing it. In other environments, everything's new, everything's novel. You're just like, well, I'm not quite sure how to proceed here,
Yeah.
So, I can understand why when guys come back and they get out, that they just are, discombobulated, on multiple dimensions, because nothing is set, and you don't know what script to follow, really.
Yeah, and so. What are you seeing? And I guess we can, before is another part of the introduction for you. You're not just medically focused, but you're also looking at the patient's mental health in some capacities as when you work with them. And you yourself, you do a lot of outdoor activities, Spartan Racer. What else?
Oh, as far as exercise?
Yeah.
Oh, yeah. I mean, I love being outdoors. Spartan races are great. They're sort of like my reason for working out.
Yeah.
So I have a whole workout program that I do. I started working out. I've always been thin. I played soccer, college ball, soccer, but I was a thin guy that could run, forever. I didn't really work out with weights. Once I got out of residency, I started working out more with weights, initially primarily just as a stress reliever. I need to do something physical, because so much of what you do as a doc is mental, and that can fatigue you. But it's not the same thing as actually physically working out. The other part of physical working out also engages, parts of your brain that you have not been engaged with during work, and so you're able to just de-stress and leave those things behind.
So is some of those are just like, is it like, I don't want to say atrophied, but they're just kind of left dormant while you're just doing...
Left dormant. I mean, you've just think about it. You've gone through 4 years of medical school, which is just the most intense mental game you could possibly do, memorizing vast amounts of information and processing. And then you go into residency, which is just a beat down from the get-go as far as just taxing you mentally, emotionally, psychologically, where you're managing patients and the attendings are stressing you because they want to know that you can actually perform when they let you go in 3 years, and so it's rightfully needs to be that way. It is a cauldron. It is a training under fire, so to speak.
Yeah, it's your own version of selection.
Yes, it is. Absolutely.
Yeah.
Absolutely. And so it's our own version of combat, I suppose. There's a lot of parallels with vets in combat with that. But they want to know that you know what you're doing, and you can handle yourself alone once you get out as a physician, The problem with all that is it has occupied so much time, to studying all that kind of stuff. You don't really do anything. You're probably the most out of shape that you've ever been in your life when you finish with residency. And then they say it takes you an average of 5 years to recover from residency as far as sleep cycles and all that kind of stuff too. So there's a lot of things working against you, and then you're starting a new job as a career, and suddenly you're also, no one's looking over your shoulder. And so, there's so many stresses there. So I just did it as a way of just relieving my brain so I didn't have to think. I wanted to work hard physically and sweat and huffing and puffing and all that kind of stuff just so I don't have to think, and to relieve my head. And then, so then I thought, well, there needs to be a purpose for what I'm working out. So I actually then started getting on a plan, talking to some of my friends that actually worked out and that kind of stuff. And then the Spartan races were just sort of like a fun thing to do. Let's train up and get ready to do a Spartan race. And the first time I did it, I was completely sold. It was great.
Yeah.
Being outside, going over obstacles, it's very military. The Spartan version is very military as opposed to all the other like mud runs and stuff like that. There's some mud involved with the Spartan race, but it's actually obstacles and, upper body strength up and over walls and that kind of stuff.
Yeah, the rope climb especially, yeah.
Exactly.
Everybody's boot camp, I think, has rope climb.
They got to have a rope climb, yeah. Exactly. Monkey bars, and all that kind of stuff. So, and so I thoroughly enjoy it,
I'm similar to you in that way too. Is that I like being done with working out, and sometimes I like the middle of a workout when I'm in it. Mm-hmm. But it's hard for me to get motivated to go exercise if I'm not training up for an event. Yeah. I need it to build towards something.
Yeah, has to be a goal. Yeah.
Yeah, exactly. Left to my own, I'll look around. All right, do a little of this on the weights, do a little of that, and just it's not satisfying.
No, it's not. I mean, it's better than doing nothing, obviously.
Yeah.
But yeah, you need a goal, something, reason why you're doing what you're doing. So for me, the Spartan races have been just a great thing.
So let's get into how you've been working, and we can talk about vets and first responders because there's a lot of crossover there. Mm-hmm. But so I guess what makes it different to befriend some of the vets what are the things you notice that they're struggling with, or that make them better friends or harder to be friends with? I guess on the friend side.
Okay, that's a great question. Yeah, vets are unique category of people for sure. Obviously, there's points of connection that I feel with them in that my job involves a stressful environment, which mimics a lot of what they've been involved in, the stress of combat and all that kind of stuff. There's also the teamwork approach in the emergency room, which the vet has had in his platoon or whatever. I think I refer to my vet friends as one of my schizophrenic friends. And they're almost like the foreign exchange student, that comes and lives with you. They're supposed to be like you, but they're really not like you. And
you have to learn their culture.
You have to learn their culture,
right.
And I don't think a lot of the vets realize how much they've been formed by their military experience. What you were like before you were in the military and the points of contact and commonality you had with your friends before the military are now so far removed from what you actually are that it's like you don't know them anymore. And so you have to start from the beginning as far as just becoming friends. Vets also are very, I don't want to say they're not trusting, but yeah, they don't trust. Very, very they step back and want to observe and watch, and it's more of a process for them. Whereas, in the civilian life, you got one point in common. Oh, we're best buds, kind of stuff.
Yeah.
And so I've just noticed that it takes much more work to be a friend of a vet than it's someone else that's a civilian that has not actually been in the military.
Yeah, and I think that even gets magnified even more for vets who have seen, different degrees of combat or, lost friends, because then you look at the risk of trusting someone new becomes greater, the fear of loss again, of course.
Yeah.
And things that I wasn't aware of this when I got out, like why this was difficult for me to make friends, but looking back now I can see why.
Yeah.
And so it's also, I'm trying to think, I think there's a lot that goes into it in terms of trust, of just the way respect is earned.
Yeah.
In military culture, you start at the bottom and you earn respect. And then also, I think what's confusing too, and some people maybe recognize it and some people recognize it after a while, is that when you're in the military, you can see people's ranks, on their collars or on their sleeves, and their experience, especially if they're wearing ribbons or medals, it tells a story about them and how you relate to them. You get out in the civilian world, we could both be working out like in a spin class or something, and I don't know who you are, and how to relate to you in that way.
Right. Yeah, and then another factor of this is that men are just not great at making friends. You know,
No.
I mean, because we refuse to be vulnerable around each other.
Yeah.
You know, unless we get like, you know, ridiculed to death, you know.
Exactly. It just gets equated with being effeminate or gay.
Yeah,
or,
exactly.
Or just not masculine.
I mean, yeah, because would you ever like have, before you went to the military or when you were younger, ever told your friends, hey, I love you, man?
Yeah,
That
never.
would never.
Never.
I don't even tell it to my twin brother, you know. So,
Yeah.
you know, so, you know, that kind of thing is just never said, you know. And so, you know, and so we're not good at it before we even get into the military. Then you're right. Then in the military, you're in this cauldron and you've changed, but may not realize how much you've changed. And the other part of it is, we don't have the vocabulary.
Different words
to talk, you know, at that mature level, you know. And so, like one of my buddies who's living with me right now, you know, the F-bomb is a noun, is a verb, is an adjective, it's a never, you know, without that word, he'd be
It replaces
speechless.
the word
Exactly. They'd be speechless, you know, and everything.
Yeah.
And that does not translate into the civilian world very well at all, you know.
Yeah.
And so, and men are just less articulate, I think, you know, than women as far as in relations. And so,
and emotionally articulate as well.
Yeah,
I mean,
and-
like the extreme example that is sometimes true. I love to talk about is like me. I think starting out, and a lot of guys, there's maybe 3 feelings that they're familiar with: pissed, bummed out, stoked, or maybe they're just kind of okay, which
Yeah,
is
I'm okay.
anything in between,
exactly. Yeah.
including pissed.
Including pissed, exactly. Exactly. Well, and I can see why it'd be frustrating for a vet as well, because part of your experience has aged you beyond your chronological age. You know, and so when you come back to the States and you see your buddy, you know, who's the same age as you, who wasn't in the military, you guys are at such different times in life, you know, just because of the experience that you had, that there's almost no points in common with this guy. You know, and you think about, well, what was my point in common with him before? Well, we played football together.
Right.
Okay, but that's back in the past. You know, you are a completely different person with a different set of skill sets and different experiences and everything, and they are not, you know, correlated with you at all. And so there's just almost nothing in common. So then it becomes this awkwardness between you, and then of course it's not going to work. And then as a vet, you're like, you just sort of move on. You're like, well, you know, I don't find anything out of that friendship anymore.
Yeah, I mean, there's a huge, growing up process, even in the first few weeks of any kind of basic training in terms of level of responsibility and expectations,
Right.
and demands for excellence.
Right.
That to varying degrees, you know, maybe our civilian friends haven't experienced, and maybe that's due to, it's almost a nice thing because it's, you know, if you live in a place that's relatively well off or it's peaceful, then there's no reason they would have to have that level of responsibility or hardness.
Right.
You know, it's probably different, you know, for military veterans that come back in, I don't know, places in Russia or Eastern Europe or countries where it's, you know, life isn't as easy.
Right. Yeah.
But that's a good point. Yeah.
I like that your point about, you know, you can read the hierarchy on the military, you know, people, a captain versus a private and all that kind of stuff. So you can make assumptions about their competence. You know?
Yeah.
And I found that vets are very responsive to someone they perceive as competent in their field. I mean, I was sort of surprised when, you know, my vet friends wanted to be friends with me initially when I first met them, but they made assumptions about me since I was the doc. You know,
Yes.
Then therefore there's this level of respect or earned whatever respect just by nature of what I was doing and what I did. And then the fact that, you know, I would talk to them was another plus, you know, which I found that sort of weird, that they would tell me though that other yard docs you bring patients into, don't give them the time of day, you know, just ignore them completely, you know, and just move on and, you know, they're just a nobody.
Yeah.
You know,
and, you know, with military culture, the doc is also the chaplain. He's also like the therapist.
He's everything in one. Yeah.
I mean, there's that confidentiality with, you know, with your doc that you know he's someone who you can talk to.
Yeah, absolutely. And, you know, I think that also because, you know, if I'm seeing them, you know, of course, some of these guys are my friends, but they're also now become my patients in my clinic as well, you know, but there is that confidentiality by law, you know, so they feel more comfortable. They can say things that I'm not allowed to divulge, you know.
Exactly.
Outside of that. And it's not something I really thought about till one of the guys mentioned it to me. well, you're never able to say this to anybody. I'm like, yeah, that's true. I'm not.
Yeah.
Not unless I get, written permission from you. To say this.
Get that ROI.
Yeah, exactly. Exactly.
I'll edit this part out right here. How are the levels on your sound
Sounds
right
good.
now? Do they sound good?
They sound good, yeah.
Okay, cool.
Yeah, I don't.
Awesome.
Yeah, I mean, are they doing okay on this?
They're fine, yeah. As long as you can hear and it sounds good between the both of us.
Yeah,
then,
I can hear.
All right, cool.
Yeah, I'm sorry, my voice is soft.
No, and I can hear you, and that's fine.
Okay,
So-
good. All right.
Back to the show. The thing that really threw me off too when I got out is working in an office. I worked for my dad's law firm for a little while as a clerk.
Oh, okay.
And without knowing it, I was applying those same military formalities. The boss, like, "Roger that, sir. Good morning, sir."
Okay.
And after a while, because I knew him as a family friend,
Right.
my dad's boss and his partner in the firm there, and he's like, "You can just call me Rick. I mean, we've known each other your whole life." I was like, "Okay," and that was weird. Yeah.
It's funny that in Texas, it's still very common amongst events. It's yes, ma'am, no, sir, that kind of stuff. So
Yeah.
a military guy coming back using that kind of language in Texas wouldn't be seen as strange, I suppose, as we're out here in California. I suppose.
Oh, out here, they're like, you get the look of like, you're either from the South or maybe military.
Yeah.
It doesn't
wouldn't-
stick out here.
Yeah, I'm sure it does. They wouldn't think much about it in Texas.
Yeah,
But they teach their kids to say yes or no, sir. That kind of
I like that.
Yeah.
It's out here. I think the general rule of thumb or the unwritten rule is that the person has to be maybe 50 years older than you to say that.
To say that, yeah.
Some people have said, yes, ma'am, and they're like, they give me that look like I'm not that old.
Yeah, exactly.
They take offense to it. But
Yeah, I mean that still it does happen in Texas too. Even if they're your same age,
Yeah.
and you're using that, they look at I'm not that old, but it's just a common courtesy in Texas. It's not implying that you're an old maid if I say yes, ma'am.
Yeah, right.
Even though you take it that way. But
So what are you seeing medically, some of the things that are happening with vets that they're coming into either the ER or just coming into the hospital or coming in for treatment for?
yeah, that's a great question. When you asked me that, and I've been thinking about it and sort of reading up on it as well and trying to just evaluate the patients that I see. Obviously, so I see patients in two different contexts. One is in the emergency room, which I'm sort of mandated by federal law. Basically, what I do in the emergency room, it's much more prescribed and rigid. Then if I see them in clinic, that's a completely different ball of wax as a primary care. I think military men have their experience and what's happened to them in combat or whatever makes it a little different, even though they have the same medical problems that everybody else has. But the psychological component of what they experienced has a huge play in their medical issues. Like I told you that story about that guy that came in from Fort Hood who didn't want to be seen anywhere close to the base in a medical environment, and he came in complaining of back pain. And he's a young man that has had 8 tours of deployment. And I could sense immediately that was just a minor part of why he was in to see me, and he was uncomfortable because there was a nurse in the room, and then I had a scribe in the room as well. And so I just cursorily talked to him for a few minutes, and in my mind thinking I'm going to go back by myself and go talk to him. And yes, he did have back pain. Yeah, he's IED hurt him, and he was coming in for that because it was impacting his ability to work as a construction worker.
And the back pain was really like just the most socially acceptable.
It was the most socially acceptable thing for him to come in and talk to me as a doc. And the other thing was that he came to see me because I'm an emergency room doc, and he didn't know at the time that I was also a primary care doc, but I was not a psychiatrist. He was not going to see a psychiatrist, which people can find out what kind of doc you went to see, and then they make assumptions about you. Whereas if he came to see a medical doctor, that's completely legit, and yes, he had a medical problem, but he had a bunch of other psychological issues that were impacting his life. His internal world was in chaos, going through divorce, and a bunch of other stuff going on. And fortunately, I had the time that day in the ER where it wasn't too busy, where I could sit and talk to him for a good half an hour or so, and just get his whole story and find out what's going on with him mentally and psychologically, which had a huge impact on his experience of his back pain. It wasn't so much that the back pain got worse, it's that the psychological part of it made his ability to cope with it much worse. And so we had a long talk about that. And it was insightful for him to hear me tell him that, hey, this is normal to, have other issues that are impacting a medical problem. Obviously, as an ER doc, I was looking to make sure his home medical, issues were fine, and I would address all those. But I want him to know that there's other issues that he needs to address that'll help him with his back pain as well. He gave me a nice compliment when he left. He wanted to know if I had a clinic that he could be my patient in a clinic outside the emergency room. At the time, I did not have a clinic. But I was thinking in my head that this is the kind of guy I'd love to have in my clinic, because I would love to be his primary care doctor and help manage some of these things and make him a success in life.
Yeah. And, right there, that seems to be something common with a lot of vets, is just when, a vet finds someone they can trust,
yeah,
they want to stick with that person. I think the cost of trusting someone is high, or it's high upfront cost.
Yeah.
So when they have that, they're like, okay, I don't know if I can get this somewhere else. So they'd want to.
Yeah. And that's one thing you just have to explain it more to me. The ability to trust from a vet's point of view. I cognitively sort of understand what's going on, but at the other side of me, I just don't understand why it's so much harder for them than it is just a regular civilian walking through the door. And, we just happen to click personality wise and talk and, we can be friends and they trust easily. Is it just a function of having lost friends? Is it a function of, going through combat and seeing how tenuous life is, and then just your own psychological dealing with that kind of stuff and sitting with death and stuff? Does that make you have less of an ability to trust? I could launch onto something else. I think, like in religion, the ability to have faith, I think, is massively impacted by trauma. And unless trauma is dealt with and you heal to some degree on the trauma, you do not have the ability to trust. And so therefore faith is outside your scope of practice, so to speak.
Right. I mean, we look at the archetype or the stereotype of the person who goes to war, who, has a belief in has a certain faith and comes back and says, like I know a Vietnam vet who tells me, no, God died in 1967.
Yeah. Oh, yeah.
And
well, in fact, I interviewed my 8 friends about religion, my vet friends, before I came here, just to get their story and figure out where they're coming from. And this is one of the things I asked them about. And to a T, every one of them had some sort of religious belief beforehand. And since they've come back, have subsequently become agnostic, atheist. I just want to, just the here and now, just let me take care of myself. This is something I can control. The ability to have faith, they've all left their faiths, basically.
Yeah, and I was thinking about that. I think what plays into that is that growing up, let's say in peacetime, or growing up in a relatively peaceful place, and then you go off into war, there's a certain amount of assumptions you make about how things work.
Yeah.
And if you're in combat, those things can get flipped on their head. And so all of a sudden the assumptions that you thought you knew, that you could control or were in some kind of order, are changed.
Yeah.
And people question the nature of everything, whether it's functions of government, how they relate to the world, their own religion, everything. Yeah. And so all of a sudden that just becomes just another part of, well, I thought I knew this before. And now, the way people can interact with each other is much more different.
Oh,
and so how would this hold any weight? And so the level of being able to accept the unknown, you go from maybe faith is really the only unknown part in their life that they're taking on faith. And now everything is up for grabs in terms of what's real and what you have to take on faith.
Oh, absolutely. Absolutely. I mean, I come from, evangelical Christian background, and, I can completely understand if you've never seen someone die, or you've never had a friend of yours die, because you're young when you get in the military, and suddenly, IED goes off, your best bud is dead in front of you. That is a massively maturing and worldview altering experience. And you somehow have to fit that into your paradigm. And if you've been raised in the church and, life has been easy for you, you're middle class, upper middle class, you've had everything catered to you, oh, God's good, he's love and all that kind of crap. And then suddenly this happens, we say, oh, he isn't hot, He could have done something and he didn't do something. I mean, that is a complete mind warp. And if you have not prepared for that, it's completely understandable to see why I have nothing to do with faith. I don't even want to talk about God anymore. I'm going to take care of myself. That's
right.
That's a rational reaction. Now, whether or not God exists, we can talk about that some other time. But your reaction is a completely rational reaction right there. And so you're going to take your head out of the clouds, and you're going to get, okay, how am I going to stay alive? And so your world was reduced to very parochial, for the time being.
Yeah.
And you may not get out of it.
Yeah, and this goes back to, I think, Maslow's hierarchy of needs.
Oh, yeah.
Because with trauma, your basic needs of food, water, shelter, and then above that, security. Yeah. A lot of us have that to varying degrees growing up.
Yeah.
Going through trauma, all of a sudden, it's not safe to be in your body.
Yeah.
And so the higher order of things, and including spiritual matters and self-actualization on that pyramid, can't be addressed. Just like, as a therapist, I can't really do really deep work with someone if they're struggling to get food to eat or have a place to stay.
Right.
Just, they're not at that level. That's how we operate as humans.
Yeah. Yeah. So it's completely understandable, and it's a complete rational reaction. I mean, but just on the side here, I feel that the church has completely failed people in this dimension. Traumatized people, they're immediately shunned because they can't have faith.
Well, it's interesting. I wouldn't say that church or churches are alone in that. I think we have had such a massive influx of people coming back.
Yeah.
Not only, we could talk about now more than ever, just due to updates in technology and body armor, that more people are surviving.
Right.
But we have a lot more people coming back wounded.
Right.
And those people are going back and redeploying more and more and more through wars that have lasted, and the longest ones we've had in American history.
Yeah, exactly.
So to say that we are underprepared is an understatement.
Yeah.
For this. So we got a bunch of vets coming back, and everyone's not sure how to deal with it.
Yeah, what do we do with them?
Yeah,
you're right. I didn't even think about the actual vast numbers of vets coming back.
What else are you seeing in terms of, okay, so people come back, whether they have trauma or not, there's probably some other things happening physiologically, or are you seeing any trends with some of the vets who are coming in, or the literature?
Absolutely. The biggest thing I'm seeing is the constant stress of combat and being deployed. Cortisol, that kind of stuff, suppresses a lot of normal functions, and especially male body. I have a men's health clinic, and one of the big deals is testosterone replacement. And we're as a country, and as in the world today, we're trying to figure out why men have such a catastrophic drop in testosterone in comparison to our grandfather's generation, whose testosterone stayed very high for up until the 50s and 60s before it started tapering down. Now we're finding guys in their 20s who should be at the highest of their testosterone levels have almost none. There's a lot of theories. One is the big theory, which has more credence to it, is the amount of toxins in the environment from the plastics. All our plastics have estrogenic-like compounds, which are going to, impact testosterone. The American diet, when we went onto this no-fat craze, and there's the amount of sugar and carbs in the diet, that affects us immensely, affects men's health. Men are geared for meat, and I have my own theory on diet and everything we can talk about later, but so there's a number of reasons why testosterone goes down. As far as for the vet in combat and everything, that constant stress and cortisol levels suppresses testosterone production, and a bunch of other things: dopamine, serotonin, norepinephrine, the normal hormones and stuff that we have in our system that help us either jack up or calm down. We got three basic neurologic systems in our bodies. We got the sympathetic, which is the fight or flight, jack you up and then get you going, which is basically what combat is.
Yeah.
Then we have the parasympathetic, which is the calming you down, digestion, all that kind of stuff.
The rest and digest
kind of stuff, and sleep. And then you've got the autonomic, which is just an unconscious portion that causes us to breathe and our heart to beat and that kind of stuff.
Yeah.
The problem with this is that the constant cortisol, the constant stress, the kind of just suppresses your testosterone production to the point that, you look like an old man hormonally. And so then, of course, every other system that testosterone, affects is impacted. Sex drive goes into the toilet, you can't sleep. Cognitively, you're foggy in your head. You can't think. So you have interrupted sleep. And you're constantly stressed. Your adrenals finally fatigue out. They just can't keep up with this mess. You start putting on fat. The problem with fat around the middle is the metabolically active fat. That fat converts testosterone into estrogen. So not only do you have lower production of your testosterone, some of what you have is being converted to estrogen. So basically, your body's turning you into a woman because of the constant stress.
Oh, wow. I did not know that.
Yeah. So this is the reason why we're all about the metabolic fat around the middle, trying to suppress that. So that one of the trends I see in most of my vets is, I don't care what your age is. If you got any of these fatigue type symptoms, or sexual dysfunction symptoms or whatever, I'm going to do a whole metabolic profile on you. And these are the labs that most docs don't normally get. There's your hormonal panels, your vitamin panels, your minimum panels, and I want to see where you're at so I can have some idea. Okay, and a lot of what guys are experiencing, their depression and their, all this kind of stuff is just a hormonal problem. It's not because, there's something wrong with them psychologically. Depression goes up because of this, Now, you may be depressed and you may need to be addressed with that, but if I can get your hormones back in gear, this is something you can be able to manage just, with some behavioral therapy or something like that. You don't need no medication for it.
Right. So what starts out as like low testosterone or a thyroid problem or something like just physiological that can be solved in that avenue, people feel depressed. And then maybe the fact that they're feeling so depressed, it becomes psychological too. It just like builds on itself.
Yeah. Or your testosterone is low, so you have some ED issues. You have erectile issues. So then, of course, your spouse, your partner is like, well, he doesn't like me anymore, And so these marriage issues, and then you get performance anxiety because it's not working so well, and then it's just a self-feeding circle, that you just consume yourself that way. And the problem is nothing wrong with you, It's something that that can be fixed. But it's just most docs are not even going down that avenue. They're slamming you with antidepressant,
Right, exactly.
They're giving you this, they're giving you that. They're not addressing all the things that you could do that get you on board, like get your, health in gear by let's get you on a good diet that'll help support this. Let's get your sleep back in gear. All these kinds of things that don't require a lot of medication. And then let me see where you're at. How can your body recover from this before I have to start adding medication on top of it? Now, some guys' testosterone is so low, it's just like the fat obese person that comes in with, heart failure or something, like, okay, I got to start some medications initially until I can get you over the initial issue, and then we can slowly wean you off as you get in better health.
Jumpstart to inject something in there.
So let me just help you make you feel better, have you feel more like a man, and so at least you can have that part of your world working, and then we can work on the other things as well. Now, eventually, I may be able to get you off of it, but that's down the road. But at least for now, let me help you feel more like a man, help you feel better, and then we can address those things later.
There's something huge about that. I think I like that you say that, because to have that injection of hope into your life, it gives you a reason to, okay, this is what it's like. And you remember, and then you say, okay, there's something I can move towards.
Yeah.
It's almost, I think about it, if someone had, 200 pounds to lose of body fat, and they all they thought about was, my life is going to be miserable until I get, those 200 pounds off.
Yeah.
That's a long way off.
Yeah.
So the hope goes down dramatically.
It certainly does, But if you got a doc that'll help you and say, okay, give you a realistic expectation.
Yeah.
This is where you're at. Our goal is to get you over here. It's going to take us a year. And
the perspective of how
this is how we're going to do it,
is going.
And so it gives them a plan. It gives them a buy-in, and then I'm going to be with you here, and I'm going to help you feel better during the whole process, it requires more of the physician to help you with that. But I think the other part for the guy is that, okay, there's hope there, and it's not a psychological problem.
Yeah, I'm not crazy. It's not just
crazy.
something on.
Yeah, there's a physical problem, that can be addressed, and once that's addressed, it's amazing how these guys, react. I have one guy that came in to my clinic in September. He was fat, fireman, and he's lost 60 pounds. Today.
No kidding.
Yeah, since September till now.
So it was September to now.
September to now.
Okay, wow. That's a few months.
A hell of a lot of weight to lose in a few months. Exactly. But he was like, he immediately bought into the program, and it's not a program. It's just, we talked about his diet, and I got him on basically the keto carnivore diet. Cut out all carbs, I said, this is temporary, so I give him some hope. You can, you can have a pizza, 2 years from now. But, and then I corrected his hormones, and I had to get him on some supplements and various other things to correct his hormones. We got him on a good fitness program, and he really bought into it. And the amount is drastically changed his life is mind-boggling. His wife just can't believe it. He's a completely different person. In fact, you hardly recognize him when you see him,
And I'm sure the energy levels and just how we can be around people is more enjoyable. I mean, it just, like we talked about earlier before this, just the problems with something like just purely testosterone injections or like throwing an antidepressant in it is that there's the cascading effects that happen. And just like this, when someone feels better because maybe they've dropped weight and their hormones are balanced and functioning like they could, the other positive effects it has in their life.
Oh, it's huge. It's life-changing. And the problem, is a person that, has put on antidepressants, there's only one that's not going to affect a man sexually.
Yeah.
And so, but yet we just willy-nilly as physicians just, okay, this is a good one, and just put them in. We don't even ask them about the sexual side effects. And guys are not going to volunteer that kind of information. That is one of the most nerve-wracking, if you're even going to bring it up. Talk about lack of trust. Unless they're really comfortable with you, will they bring it up? I cite the physician in error in this. The physician should recognize that, hey, these are the side effects, and I'm going to ask my patient directly, hey, is this happening? Because that's an important part of life.
Yeah. Because if you're not asking it, no one's going to volunteer that potentially most emasculating or like embarrassing information, right?
Yeah. It's like, hey, I'm 35 and I can't get it up.
Yeah.
There's no guy on earth that's going to say that to you.
It's not a great pickup line. It's not a great lead into a conversation.
No, exactly. Just like, you're out there, you're fully exposed for everyone to see, when you actually say that. But if I would say, I'd like to start you on an antidepressant, and then as a doc, I'm saying, okay, these are the possible side effects. And I mention, ED. I said, and if anything like that happens, you just tell me and we can correct that, Because sometimes it requires, they may need to be on that antidepressant, but at the same time, I'm going to start them on Viagra as well, just to mitigate the potential side effect. And the fact that you've opened the door and you've mentioned it first, then the patient or the guy feels more, inclined to talk to you later about it, when it's actually impacting them.
Yeah, that trust is like you provide the space for that conversation to be had.
Yeah, exactly.
It's interesting how I think even outside of the medical field, just in general, how all the assumptions go in to if someone's not doing all right or there's an area of their life that's not going as well as it should or could, that they'll talk about it. When in fact, if there's not the space or someone doesn't have their perception that they can talk about it, they can go their whole life without addressing something that, like you said, one question, taking that like, what do you say, public health kind of approach to it, just have these questions. Something simple like that.
Yeah.
Could open the door for someone. It could be that one simple thing.
Yeah. Well, it's interesting because, I put on my initial forms that people fill out their medical history when they come to my clinic. And there's a section called the Adams score, which actually asks all these, sexual function kind of questions. All I have to do is check yes or no.
Yeah.
And then when I'm reading it, so I have some idea what I'm going to ask the patient, about. But sometimes they've left it all blank.
Yeah.
And so, I know that for them, this is very uncomfortable for them to talk about or even to admit. So then I'll initiate the conversation. And I'll sort of couch it in, this is just some general trends in the nation, men's testosterone is dropping like a rock, and it affects all these issues, and I give them some examples, like there's one kid, 28-year-old, big muscle-bound kid, his testosterone was 70. It should be 800 or to 900 at his age. And he was just fatigued, and he just had recently got married, and he was just like had no libido, and he was like, "There's something wrong with me, doc. I need some Viagra." And I'm like, "Well, wait. Let me, And so I tell the story, and I said, and so as soon as I got him on testosterone, man, everything came back to normal. He and his wife were happy. They just got pregnant, all that kind of stuff. And so, so I sort of put them in a whole context so they feel like, okay, me mentioning this is not completely outside the realm of normal. And then provide
but normalizing it. That's a huge thing. Yeah.
Well, and and guys don't talk unless you directly ask them a question.
Well, yeah, and that leads to all kinds of just psychological problems. If someone has the idea, this is something that's only me, no one else has this problem.
Yeah.
And then there's no way I can talk about it. Right. And that just adds a whole level of mental stress and mental health problems the longer it goes on.
Absolutely.
How does sleep fit into this? Because what I understand about sleep, you talk about elevated cortisol levels, doesn't allow a lot of the other hormones and vital functions we need to take place. So from what I understand, it seems like the pop science way of saying is the sleep you get before midnight is the most restorative in terms of repairing, damage done during workouts or whatever else.
Yeah. Okay. The reason why they say that is because you want it when you first go to sleep, you go into really deep sleep.
Okay.
And you need the deep sleep where you get everything gets sort of restored in deep sleep.
Is that the delta wave?
The delta wave, yeah. And then as the hours progress, you slowly come into a less deep level of sleep, but you have the more REM.
Right. Okay. That's where you remember your dreams right before you wake up because you're getting more REM.
And you have to go into the deep and have REM to have restorative sleep. And then the numbers they're punting around now is like 7 to 8 hours of good sleep to fully recover.
Okay.
And it's amazing if you can get a person to sleep well and you can get them on a good diet, how massively restoring and healthy that is for a guy, or anybody really, but we're talking men here. That if you can get that to happen for them, all the rest of these medical issues and psychological issues and depression issues, they're vastly mitigated or go away completely.
Yeah.
And yet we as a society, we're Americans, man, we're industrious. We work hard, We get 5 hours of sleep and then count that as a good night. No wonder why we're like in our 40s and we're like actually 80, metabolically, is because we have not ever allowed ourselves to recover. Add that to the vet, who's been under massive stress for all these multiple deployments, all that kind of stuff. And even now as a civilian, they're not sleeping well. Across the board, none of them sleep well.
Of course. And I imagine it's just gotten worse as we have the ability to watch movies on our phones.
Yeah. And they talk about the blue light on all of our electronic devices.
Which is essentially telling your brain, hey, this is morning sunlight, time to wake up and elevate your cortisol levels, which you want in the morning.
Exactly. Which is why, on the side, why we have more heart attacks in the morning than we do in the evening.
Really? Okay.
Cortisol is jumping up.
Interesting.
Activating the system.
There's so much that goes into this, too, because I talk to a lot of vets who aren't able to sleep until it's daylight again. Because a lot of them will talk about how, especially I think in Afghanistan or especially in Vietnam, all the attacks came at night.
Yeah.
And a lot of them came just before dawn. Mm-hmm. That's like the prime attack of base hour.
Yeah. Yeah.
And so people don't feel safe. They don't feel safe to sleep until they can know it's light out. So less likely to be attacked.
Yeah. Yeah. And a lot of the vets that come back and they go into fields like police officers or fire departments or EMS where they have erratic schedules.
Right.
I know exactly what it's like as an ER doctor. I have to do shifts, night and day shifts. Every month I'm switching my sleep cycles. And that massively impacts your health. Just the lack of sleep in one night. You're susceptible to any type of virus that's going by. And I recognize it, and so my goal is to have all the guys in my clinic, whatever, I'm going to try to maximize your ability to sleep. So when you can sleep, you need to make it good sleep. There's a lot of things we can try to do that, we're just going to have to deal with the erratic schedule that the firemen have. Every third night, they're going to be awake half the night, that's just part of their job. But their studies show that you can live 10 to 15 years less than someone who doesn't do that.
Yeah, and that's been coming up in a lot in the different, health fitness podcasts I've been listening to. Just the talk about the detriment of shift work
disorders,
and overnight stuff. Yeah,
we now have an actual medical diagnosis for it and a couple medications for it. Like Nuvigil is a great medicine to help.
Obviously, a lot of reasons why sleep is an issue for the vet community.
Yeah.
Just civilians, like I say, Americans in general are getting way less sleep.
Yeah.
And getting way less quality sleep.
Yeah.
Probably, whatever proportion, but a sizable is from smartphones and the ability to look at Facebook and watch movies at night.
Right. Yeah. I've talked to, my vet friends about their quality of sleep, and it's interesting, they say our sleep sucks, across the board. Some sleep better than others, but there's a component that you might be able to talk about more that I don't understand as much as that most of them have dreams about combat, especially the ones that have more PTSD, and there's always one particular dream that they have over and over again.
Right.
And so they do not want to go to sleep.
Yeah.
So they're, even when they're sleeping, they're tense. It's like they're still waiting for, an ambush out, somewhere. And yet they're back in, Fort Worth, Texas, sleeping in their own bed. This is not going to happen. But the ability to turn that off and to deal with the dream. And they've asked me about it, and I'm like, besides anesthetizing you, which I can do as a physician,
Yeah.
I'm not exactly sure how you process it psychologically so that does not come back.
At this point, the noise in the background got pretty loud, as you guys can probably tell. So Luna and I relocated to a quieter place, which actually was a nice time to stop and record part 2 of the episode, which I'll have for you guys next week, so stay tuned. And we really get into some more stuff concerning men's health. All right, everyone. Until then, drink water, meditate, kill bodies.